Hello everyone, welcome back to Comment Made Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. We have finally arrived to the last part of the lecture on tuberculosis. Let us start with some special situations. The first one is tuberculosis and HIV infection. So this is very important. There is something known as HIV-TB coordination. So what does it mean? One of the most common opportunistic infections in HIV is tuberculosis. So whenever we come across a patient of HIV, it is mandatory that we know his status of tuberculosis infection. So we have to go for some investigation method. Similarly, if we come across a patient of TB, we must know his HIV status. So that means whenever we come across any patient having one of these two diseases, his status for the infection of other type of disease must be known. What happens in HIV infection? We know that in HIV infection, the immunity is suppressed or compromised. So because of that, if there is any dormant bacteria in the body, so this latent infection can be reactivated and the disease can occur in the person. And whenever tuberculosis occurs in a person having HIV infection, it is mostly of severe kind. So there may be a lot of complications associated with that. Now, diagnosing TB in HIV infection can be a little bit tricky because in most of the times the sputum is negative or the X-ray findings may not be suggestive of tuberculosis. Also, there are a lot of extrapulmonary cases of tuberculosis in HIV infection. The next one is tuberculosis and diabetes. So again, diabetes affects lots of organ and also causes some disturbance with the immunity, or you can say some suppression of the immunity, and again because of that there is high chance of tuberculosis. Tuberculosis and tobacco, tuberculosis and COVID-19. So COVID-19 is very important in current scenario. People having long-term exposure to tobacco, especially smoking tobacco, or people who had COVID-19 infection, so these people will have pathological changes in their respiratory system. So in the bronchus that will be compromised, and because of this chronic or long-term insult to the respiratory system, these people are always at higher risk to develop tuberculosis, and the disease can be severe in them. Tuberculosis and pregnancy is another very special situation. So let us discuss tuberculosis and pregnancy in details. Tuberculosis and pregnancy. So all the drugs that we use as first line treatment for TB, for example, isoniazid, rifampicin, pyrazinamide, ethambutol, all these drugs are safe. But streptomycin, which was previously used as first line drug, it is not safe in pregnancy because it is ototoxic to the fetus. So because of that, it should be avoided during pregnancy. Now, if a mother has tuberculosis and she delivers a baby, we must first rule out that the baby is not suffering from tuberculosis. So there is no active TB in the baby. After that, since the baby will be in close contact with the mother, that means it will always be exposed to the infection. It can get the infection from its mother. So we must give some kind of prophylactic therapy. So that is why isoniazid preventive therapy is given for 6 months. After that, BCG vaccination is given. BCG vaccination is ideally given on the day of birth or as early as possible, but it can be given up to 1 year of age. But in this case, when a baby is delivered of a mother who has tuberculosis, BCG vaccination is not given on the day of birth or as early as possible. First, we give 6 months of isoniazid therapy, which is a chemoprophylaxis. After this chemoprophylaxis is over, then we give the BCG vaccine. We have so many times talked about the drug resistance tuberculosis. So what are the different reasons of drug resistance tuberculosis? So from a microbiological perspective, drug resistance occurs when there is genetic mutation of the bacteria. So now the drug which was previously working against the bacteria will not work anymore. So that means we can say the bacteria or the bacilli has become resistant to that particular drug. Now in clinical setting, that means what we do in the field, inadequate and poorly administered treatment regimen can cause drug resistance. This means if we give the wrong regimen to the patients, or if we give the right regimen, that means the right drugs, but maybe in the wrong dosage, that can lead to drug resistance. It happens when we give the right drug in the wrong dosage. The serum level that is necessary for the drugs to act on the bacilli is not reached, and because of the suboptimal level of these drugs, there can be development of resistance. And from a programmatic perspective, delay in detection or effective treatment, so this can also lead to drug resistance. And obviously this is very difficult to manage the drug resistant patients, because we may have to tweak the different regimens to see which one works. What are the different type of drug resistance? It can be primary or pre-treatment resistance. That means the bacteria shows resistance to the particular drug even before the treatment is started. Secondary or acquired resistance means initially the bacteria was sensitive to the drug, but with time it has developed resistance to the particular drug. So initially the drug was working, but later the drug stopped working because the bacteria or the bacilli have developed resistance. So that is secondary or acquired resistance. What are the treatment for drug resistance tuberculosis? So let us look at the drugs first. So we have different groups, group A, B and C. In group A, we have 3 drugs. We have to include all of them. So levofloxacin or moxifloxacin, which are basically fluoroquinolones. Along with that, bedaquiline and linezolid. In group B, we have to add any one or both the drugs. So we have clofazimine. Along with that, we have cycloserine or terizidone. Now terizidone is not used very commonly yet. Group C, add to complete the regimen, and when medicines from group A and B cannot be used. So these are the drugs which can be added. We have ethambutol, delamanid, pyrazinamide, imipenem, silastazine or meropenem, amikacin or streptomycin, ethionamide, prothionamide and para-aminosalicylic acid. So these are the drugs which are used in combination, in different combinations for treating drug resistance tuberculosis. Now there are a lot of regimen available, and this regimen also keep changing. Now I have mentioned here 3 regimen: shorter oral regimen, shorter injectable regimen and longer oral regimen. I will request my student to remember at least this one, shorter oral regimen containing bedaquiline, because this is very commonly used nowadays. If possible, you can also use this injectable regimen or the longer regimen, but this one you should remember. Also, as I mentioned in my previous videos so many times, that by the time you will appear in your exam, maybe there will be some newer regimen for the drug resistance tuberculosis. So please keep yourself updated, and if there is any change in the regimen, please follow that regimen. But the regimen has to be from a reliable source. Just do not follow internet or any notebook or any printed material just like that. It is ideal that we should look for documents from Ministry of Health and Family Welfare, Government of India, or even your state specific government sites. That will be more reliable. So let us look at the shorter oral bedaquiline containing regimen. So we have 4 to 6 months of bedaquiline. Along with that, 6 months of levofloxacin, clofazimine, pyrazinamide, ethambutol. HH is high dose isoniazid and ethionamide. What is ETO? ETO is ethionamide here. Or we can give 5 months of levofloxacin, clofazimine, pyrazinamide and ethambutol. Intensive phase can be extended to 5th or 6th month based on smear result at the end of 4th and 5th month of treatment. So if at the end of 4th month we see there is no bacteria or bacilli present in the sputum, we can go for the continuation phase. Otherwise we have to extend the intensive phase if needed. There are also injectable regimen containing kanamycin, amikacin. These are the injectable preparations. There we have longer oral regimen. So if you want, you can remember these things. But this one, the shorter regimen, that you have to remember, and you can write this one in your exam. That should be enough. We discussed few of the newer initiatives, and we shall continue with the newer initiatives in today's video. The first one is NICSHA. So it is an IT enabled compliance system. So information technology enabled compliance system. So whenever a patient is diagnosed with tuberculosis, all his details, his name, his registration ID, his address, type of tuberculosis regimen, everything, every details is registered in a software, in an app, that is NICSHA app, which is available. And the patient receives SMS alert which reminds him about the drug. That means he is reminded that the person has to take the drug daily or on a particular time as needed. Using voice response system, it provides some voice response to the patients to help them regarding different problems they face during taking the drugs. If they need any instruction, that is also available. So this is NICSHA. There is NICSHA Poshan Yojana, which is basically providing nutritional support to the TB patient. Financial incentives of rupees 500 per month to each patient to buy food. So the patients are given 500 rupees every month so that he can spend it on buying food. 99 dot strategy, which is missed call alert, and I shall show you this in next slide. An incentive to the treatment provider. So the person who is giving the drug administrator or the DOTS provider, he or she is also given some incentives provided he follows certain criteria. That means the person or the patient fulfills his regimen, completes his regimen, I mean, and there is no loss to follow up, there is no default, etc. So all these things, if these criteria are fulfilled, then the person who is providing the drug, he is given some incentive, which obviously acts as a motivating factor for that person. Now, what is 99 dot strategy? So 99 dots introduces anti-TB blister pack wrapped in a custom envelope, which includes hidden phone numbers that are visible only when the doses are dispensed. So we know this is what our anti-tubercular drug strip looks like. This is the envelope, the customized envelope. So the drug is put inside this envelope. All right. So whenever a person opens this part of this blister pack from behind this envelope to take the drug, so that he can take the drug, he will see that there are some hidden phone numbers given here. This is otherwise not available unless the patient opens the blister pack, and only then he can see this. After this, he is supposed to give a missed call to this number. Okay, so the person does not have to call, he just have to give a missed call, and from that it will be registered that the patient had opened this blister pack at that point of time. That means the patient had taken his drug. So this is what 99 dot strategy means. Now coming to prevention of tuberculosis. So far we have discussed the diagnosis, the treatment, etc. But how we can prevent the disease? Now BCG vaccine, we have heard about that. That is Bacillus calmette-guerin vaccine. It is a live vaccine derived from an attenuated bovine strain of tubercle bacilli. The strain, the name of the strain is often asked during Bible. That is Danish 1331 strain. It is a freeze-dried vaccine. That means it is available in powdered form. We cannot inject powder, so it has to be reconstituted. So the diluent here is the normal saline. Another very important Viva question. It is heat sensitive, especially reconstituted BCG vaccine is probably the most heat sensitive vaccine. What is the schedule? Single dose is given at birth or as early as possible till 1 year of age, usually using an auto disable syringe. So only one dose is given, there is no need of multiple dose, and it is given at birth or as early as possible. But if the situation demands, then we can give the vaccine up to 1 year of age. So if we cannot give the vaccine initially for any reason, maybe because of unavailability of the vaccine, or as I mentioned earlier, if the baby has to be put on isoniazid preventive therapy, so in that case the vaccine may be delayed and it can be given up to 1 year of age. What is the dose? If it is given before 28 days, then the dose is 0.05 ml. But if it is given beyond 28 days, then the dose is 0.1 ml. Site is left upper arm. Many of us have a scar at the insertion of deltoid on the left arm, and root is intradermal. So all these are very important for Viva question. When you are asked to pick a vial of vaccine, or you can be given a BCG vaccine vial, and these relevant questions may be asked to you. Now the next point is, or next part is the tuberculosis preventive treatment. Now this is something which has not been included in PARC yet. This is a very new thing. So there are certain people who are eligible to get preventive treatment. That means they do not have the infection, they do not have the disease yet, but still they need some preventive or prophylactic treatment. So expanded eligible group including children more than 5 years, adolescents and adults of household contact of pulmonary tuberculosis patients notified in NICSHA from public and private sector. So who are the target population? So these things are mentioned here. People living with HIV, that means they are on ART or antiretroviral therapy. So adults and children more than 12 months of age, or infants less than 12 months with HIV in contact with active tuberculosis, or household contact below 5 years of pulmonary TB patients. So all these people are qualified or eligible to start the tuberculosis preventive therapy. Also household contact of 5 years and above of pulmonary tuberculosis patient, they are also eligible. There are some expanded target population like people who are on immunosuppressive therapy, having silicosis, on anti-TNF treatment or tumor necrosis factor treatment, patients on dialysis, or preparing for organ or hematological transplantation. So because of any transplantation, the person's immunity is intentionally compromised or it is suppressed with steroids or other immunosuppressive agent, and they are at higher risk of developing tuberculosis. So these are the extended target population. So all these people are eligible for tuberculosis preventive treatment. Because of their situation, they are at higher risk of tuberculosis infection. What are the regimen? I have mentioned 4 regimen. Any one can be used. For example, 6H. 6 means 6 months of daily isoniazid monotherapy. Monotherapy because only of one drug. 3HP is 3 months of weekly isoniazid and rifampicin. 6LFX is levofloxacin. So 6 months daily levofloxacin in context of multi-drug resistance or rifampicin resistance tuberculosis with fluoroquinolone susceptible index patient. And 4R means 4 months daily rifampicin in context of isoniazid resistance with rifampicin susceptible index patients. So these are the regimen that can be used in tuberculosis preventive treatment. Let us talk about the NTB strategy. So far, we had the DOT strategy introduced in 1994, the Stop TB strategy introduced in 2006, and then the NTB strategy was introduced on 2015. So we have certain baseline data of 2015, and as compared to that, we want to reach a target by certain years. So SDG, that is Sustainable Developmental Goal, which has aimed to eliminate tuberculosis by 2030, and NTB strategy has targeted to eliminate tuberculosis by 2035. So what are the vision and goal of NTB strategy? The vision is to have a world free of tuberculosis. That means having 0 deaths, 0 disease and no suffering due to tuberculosis. And the goal is to end the global TB epidemic. So we have to have some targets for that. Now, as I mentioned, we have certain data, baseline data for 2015. Now, what are the indicators? Reduction in number of TB deaths compared with 2015. Means whatever is the number of TB deaths in 2015, by 2035 it has to be reduced by 95%. That is the target as per NTB strategy. Similarly, the number of TB incidence rate 2015, it has to be reduced by 90% by 2035, and we shall achieve this target when we have less than 10 cases per 1 lakh population. Also, catastrophic cost due to tuberculosis should be 0%. We already discussed what is catastrophic cost due to tuberculosis. So this is the current global trend decline. That means we are having less and less number of cases every year. So there is a decline in cases of tuberculosis, but the rate is very low. So this slope, as you can see, this is not very steep. This is quite flat, as you can see. But we want to reach here by 2035. That means having less than 10 cases per 1 lakh population. We have certain pillars that can help us achieve the NTB strategy. Pillar 1 is integrated patient-centered TB care and prevention. Pillar 2 is bold policies and supportive system, and Pillar 3 is intensified research and innovation. So of course, without research, without innovation, we cannot come across newer diagnostic techniques or newer treatments, especially in case of drug resistance tuberculosis. Since we are having so much drug resistance among the bacilli, we have to go for newer molecules or alternative regimen, and for that we need to have intensive research. There is obviously need for support from the state and central governments and other non-government organizations so that we can approach all the patients with tuberculosis, motivate them to start the medication, and to monitor their treatment. Coming to the last part of today's lecture, that is 90-90-90 strategy in tuberculosis. Now do not confuse this one with the 90-90-90 strategy in HIV/AIDS. That is a different thing, and for tuberculosis also we have a 90-90-90 strategy. So we have 390 here. The first one is we have to reach at least 90% of all people with TB and place them on appropriate therapy. That can be first line or second line, or even preventive therapy as required. So all the people who are suffering from tuberculosis, we have to identify and approach at least 90% of them. As a part of this approach, we have to reach at least 90% of the key population. So all these people who have been identified and approached, at least 95% of them should belong to the key population. That means people who are most vulnerable or underserved or at-risk population. So we are basically focusing on the people at risk or people who are vulnerable. Then we have to achieve at least 90% treatment success rate for all people diagnosed with TB through affordable treatment services, adherence to complete and correct treatment, and social support. So all those people who have been approached, when we initiate the appropriate treatment regimen, 90% of them must have treatment success. So the treatment success rate should be 90%. So this is the 90-90-90 strategy in tuberculosis. So with this we conclude tuberculosis. I hope this video or this lecture actually benefits you. So if you like the video, please subscribe to our channel and share this video with your batchmates, juniors and friends from other colleges. We also have our Facebook page that you can follow. The link is given in the description. Take care, and we shall see you in our next video.